So, welcome everyone to the TAS podcast. We hope everyone's had a good summer and we're excited for today's discussion. Our topic is the question of, is military trauma generalizable to civilian trauma? And I must admit that I am probably just as knowledgeable about military trauma as our average listener here. Obviously, this is a big topic, and so we'll focus on blast injuries, pre-hospital care, and the differences in training.
We're very excited for our expert panel today. Dr. Michael Murray is a retired colonel in the U.S. Army Reserve who served several tours of duty with the U.S. Army in Iraq. He's now practicing as an intensivist and anesthesiologist at the University of Arizona Banner Medical Center in Phoenix. Dr. Hans Garcia is an anesthesiologist intensivist and the chief of ORs at the Military University Nueva Granada in Bogota, Colombia. He's also an active duty colonel in the Colombian Army. Dr. Rick Dutton is a former Navy physician and the former director of trauma anesthesiology at the Shock Trauma Center in Baltimore. Today, he is the chief quality officer at USA Anesthesia Partners. Welcome, gentlemen.
Hello, glad to be here.
Good morning.
Morning, thank you for the invitation.
And so first, we'll start with Dr. Rick Dutton. We often hear that military trauma is different than civilian trauma. In what ways is combat trauma similar to civilian trauma, and how are they different?
Well, I think the similarities are easier to start with because they're obvious. Holes in blood vessels, broken bones, damaged tissue. It really doesn't matter how it happens. Very often the common pathway is the same. The tissue injuries are similar and the physiologic effects are similar, particularly in very acute injuries. Shock is a final common pathway for a lot of traumatic injuries, and it really doesn't matter how you get there. What's different about military injuries, I'd say probably three things. The patients are much healthier to begin with. We're talking about combat casualties. The wounding mechanisms are somewhat different, and that does produce a different spectrum of injuries. Dr. Garcia will talk to that in a second. And finally, in the military environment, can be very austere. You can be very far removed from definitive care. So whereas in the US, I think something like 3/4 of the population is within 30 minutes of a major trauma center, and you can be in an operating room very quickly. In military trauma, you can have substantial delays in transport to get the patient to definitive care.
That's great. Dr. Garcia, Dr. Murray, do you have anything you'd like to add?
Well, it's interesting. I'd like to hear from Dr. Garcia, but when I've lectured in South America before, and south of the border in North America, the most common comment I hear is that in the drug wars that can occur in different parts of North and South America, they'll see the same sort of injuries with high velocity wounding mechanisms. Don't necessarily have the same kind of blast injuries, but certainly a lot of the others. And so there may be more commonality than we're willing to admit. Maybe in the United States, we don't see the same sort of injuries unless we're in a combat situation. But I think in other parts of the world, they may see it more often.
Certainly in Baltimore in the late 1990s, automatic weapons hit the street, and civilian penetrating trauma became much more similar to military penetrating trauma. In the 80s and early 90s, our patients in Baltimore would come in with one or maybe two holes, often from a relatively low velocity weapon, a handgun. But by the late 90s and into the 2000s, we were seeing a lot of automatic weapon fire on the streets.
I would like to say that definitely we have to believe that there is a connection between military trauma and the civilian trauma. And for example, what happens in many of our hospitals in my country, in Colombia, that in the last maybe 50 years that we have been in some troubles with these drugs dealer and terrorist groups like the guerrillas. Maybe we have been involved in taking care of military trauma patients, not just in our military facilities. So many hospitals have been in charge of taking care of these kind of patients. So we really believe that we need to share the protocols, the guidelines, and maybe many of our hospitals and our physicians are really well trained, unfortunately, in trauma care.
We'd like to focus a little more on two specific areas of military medicine that seem substantially different from those of civilian medicine, and that would be blast injuries and pre-hospital care. Most civilian centers worldwide probably are comfortable or familiar with treating blunt injuries and burns, and many of them are comfortable treating penetrating injuries. Dr. Garcia, how are blast injuries different from these?
You're right, Kevin, and that's really interesting. In the civilian trauma centers, as you said, maybe penetrating trauma, blunt trauma from some car accidents or whatever. I think that the healthcare teams are more familiarized with the treatment for this patient. But when we talk about blasts, I think that it's definitely maybe a nightmare because we can combine different mechanisms in the people that survive to the first wave. So at the beginning, we can say that maybe it's a syndrome and it's a potential life-threatening with a multi-system disease. So what we can have is different times from the explosion, and it will depend about how is the proximity, how close are the people involved in this kind of explosion. So I think that we can maybe talk about some different types of these kind of injuries related with blasts. The primary blast injury is just related with the blast wave or the shock wave, and unfortunately, the mortality is really high. It will depend how many people these terrorist groups, if we are talking about these bombs attack, even in some civilian targets, we can say that we can have a great number of people dying just in few seconds. The secondary stuff important in this mechanism is that after the shock wave, we can have maybe some penetrating trauma, and it's related with all the things and the parts, and maybe we can think in these suicide guides as his own parts of the body can be an arm and can make penetrating lesions. The tertiary cause that we can find in this kind of blast injuries is when the people close to the explosion is deployed or is hit by other things around it. And finally, we can say that we have a quaternary relation that's related with other injuries like burns, like toxic gases. Actually, we had a problem in our country with these improvised devices that the guerrillas had, and they used to contaminate with fecal-ices. So when we have been taking care of these kind of injured people, the contamination, the bacterial infections were really hard to treat. And sometimes this is the biggest problem that we had taking care of these patients.
I just want to make sure I heard you correct, Hans. You said they contaminate with feces?
Absolutely. Yeah, they were trying to do more damage that they can do it with the improvised device. And absolutely, that's not talking about the the politics for a regular war, but we are talking about the war against the drug dealers and against the guerrillas. And this kind of guerrillas was really involved in drug trafficking. So they don't take care, they didn't take care about the rules for the war. And that's interesting. And we had really sick patients related with these kind of infections.
Dr. Murray, did you see similar types of improvised weapons in Iraq?
Well, it's interesting, and I think it's a timely topic because outside of the United States, IEDs are the preferred weapon of choice for terrorists. In the U.S., we tend to deal more with mass shootings. But in that scenario, there's also a differential between what happened in Iraq and then what happened in Afghanistan. And in Iraq, a lot of the military were traveling in Humvees or armored vehicles, and therefore, if they were targeted by RCP or rocket propelled grenade, whatever, and it exploded within the confines of the vehicle, the shock wave built. There were many more burns that were presenting to the Walter Reed and to Brooke Army Medical Center. In Afghanistan, it was a different kind of injury because now they were talking about dismounted complex blast injuries. They came up with a new term with it. And in 2013, I think there were 16,000 IEDs in Afghanistan. So a lot of experience was gained, and it wasn't just the primary, secondary, and tertiary injuries we were dealing with, but the different body parts, if you will. There were far more amputations in Afghanistan than there were traumatic amputations in Afghanistan than there were in Iraq. And likewise, in Boston, during the Boston bombing, there were probably as many multiple amputations as there were single amputations. And for every amputation, you had 6 individuals with serious injuries. So I think it behooves all of our listeners to become familiar with this topic because it will only increase with time, the use of IEDs. That's my personal belief.
So along with pure blast injuries, it seems like burn injuries can be more severe, both from the heat of the explosions and from other chemical compounds like white phosphorus. Is the burn care any different for military trauma than it is for civilian trauma?
I think the fact that the major burn formulas back in the 80s and 90s, one was at Parkland, one came out of Brooke Army with Basil Pruitt. I think there were a lot of similarities, I'd have to say, though. In the military setting, the helmets would focus the blast waves, and in the Iraq conflict, there were 150 soldiers, service members, who had their entire scalp burned off. We're talking eyelashes, nose, ears, etc., who were potentially candidates for face transplants, but that's a whole other different story. I don't think the burns that we typically see in a civilian population would match those that are seen in a combat situation, but there are a number of similarities in terms of resuscitation and how that's done in the major complications afterwards.
If I understood you right, it sounds like the care for burns is the same, just the severity and the extensiveness of it seems to be increased in military trauma.
Yes, I mean there's a whole school of developing weapons, thermal bombs, if you will. I forget the exact terminology, about creating more casualties. The United States has it, and all the other countries, Russia, etc., have it, and it's only a matter of time before that gets into the hands of rogue states or others where the extent of injuries will be significantly increased.
Yeah, it's a direction, it's a situation where civilian and military trauma are moving in opposite directions. In the civilian world, primary prevention has worked very well. So things like smoke detectors, CO2 detectors, non-flammable pajamas, you name it. A lot of the primary prevention mechanisms has really reduced the incidence of burns in civilian trauma to where it's very rare now, whereas obviously the military has been going the opposite direction.
Well, I guess the biggest influx of burns I see is from turkey fryers every Thanksgiving.
Yeah.
Yes, that's exactly right.
Exactly.
I think that Dr. Duran has right, and also Dr. Murray, but what about these new civilian attacks that we have seen in many cities around the world? And I think that the types of lesion that people have and when they are arriving to the trauma centers to the trauma bay are really similar to military trauma. So we can see again these kind of burns related with blast, and maybe in military trauma, blast could be the first cause for burns. Maybe depends. Maybe it depends with the kind of the military force. If we are talking about the infantry or special forces, and maybe high velocities weapons could be the cause, but maybe landmines. And if we were talking about these attacks for the Humvees or helicopter crashes or some accidents in some military boats, I think that we can have the same profiles from these military scenarios related with blast. And I really think that blast is the first cause for burns in war trauma. I don't know, what do you think about that, Dr. Duron or Dr. Murray?
Well, the point is well taken. And if you look at where terrorists are planting their IEDs, if you will, in Paris, they were on the railroads, and in London, we've had bombs and buses. And as in a Humvee, if the blast is confined in a space like that, the heat builds up, in milliseconds, and the burns, as you say, are very similar. And then you now have an individual coming in not only with third-degree burns over most of their body, but also with their face in it. As an anesthesiologist managing an airway, that presents a unique problem.
Thank you. That actually might serve as a segue into our next topic, which was pre-hospital care, which obviously is going to involve some airway management for some of these burn patients. Militaries are spending a lot of time thinking about how to evacuate casualties from active combat situations. Dr. Murray, what are some of the unique challenges of pre-hospital care in combat?
Well, as Dr. Dutton already kind of alluded to it, it's not always possible to extract personnel from a combat zone if they're under fire. But the same thing occurred in Las Vegas during the shootings there a couple of years ago, where the firing continued and it's not possible to extract individuals. But in a military situation, it may be hours before service member can be extracted. And it was always interesting to me, at least in Afghanistan and Iraq, the number of soldiers who arrived who were hypothermic, and then you develop the triad of coagulopathy. And it took several years, but even the dust-off pilots all were committed to keeping their helicopters warmed and maintaining the temperature of the patient coming in. But now the current problems that arise come up in the Horn of Africa, where we don't have established bases, where it may be a day or two before a service member can receive definitive care. And in the scenario for which the military is preparing now, if we ever had a conflict with China, it could be more than a few days before a service member can be extracted and transported to a higher level of care. Within the normal scenario of transport, there's 5 different echelons. There's a battalion aid station, and then a forward operating base, and then to a combat support hospital. And then from there, at least in Southwest Asia, Africa, patients are transported, not just U.S. service members, but the U.S. military was transporting service members of all other countries into Landstuhl and then distributing them either to Rome, London, Birmingham, or Nottingham, and then back to either Brooke Army Medical Center or Walter Reed, which was their Tier 5 hospital facility where they received, the definitive care. But the military has built up an entire system of transporting service members back in as timely a fashion as possible.
Yeah, thank you for bringing up Las Vegas. I can weigh in on that. So this was the worst mass shooting in U.S. history. I think it was 50-some people killed and hundreds injured. A sniper at high altitude, he was on the 30th floor of a hotel, opened fire on a country music festival. And as Mike said, there in the early stages of that event, people were pinned down, and it was difficult to get them out. As it happens, the majority of the casualties there wound up at the closest hospital, Sunrise, in Vegas, where my practice works. So I participated in several debriefings after the event to talk through it with the hospital, the local EMS, and the physicians there. And one of the interesting characteristics, first of all, patients did reach the hospital very quickly. When you shoot up a country music festival in the US, it turns out there are a lot of ex-military and a lot of ex-military corpsmen in the crowds. So most patients actually arrived at the hospital by private transport. They got tourniquets put on at the scene. All the men arrived without shirts because they'd all been turned into bandages and tourniquets in the back of pickup trucks. And the hospital was deluged, and there's a whole issue there, although they ended up doing very well with it. But it was interesting that that event almost completely bypassed traditional EMS in the United States, and that most of the patients received buddy care from other civilians and then arrived at the hospital through private transport.
Dr. Garcia, when I visit Colombia, you actually had an interesting story about friendly fire involving a grenade launcher. That had all sorts of implications for transportation. Would you mind sharing that with us?
Well, I will try to be short. And one of the other problems that we have here in our country is that we had the troubles in the jungle. We don't really have the troubles in the cities. So our soldiers were maybe walking in this kind of a scenario of operational theater for 4, 6, even 8 months, walking and trying to pursue these guerrillas. So one of the big issues that we have when we have some combat casualties or people injured in the field is the area and the weather and the intensity of the combat. So I think that in military trauma, when we're talking about how can we take as quick as we can our injured people on the field, there are other factors that maybe we can modify, and we saw maybe an increased mortality when the water was impossible for helicopters to go to this injured point. So these conditions could be really increasing mortality in different kind of wars, regular wars or this kind of guerrillas war. The interesting thing is that our soldiers on the field, we have been preparing them, teaching them, and I think that right now there is a really big process for maybe is the TCCC training program, and we will really believe that our nurses in the military field have not the enough resources. We can say that they're still working in a real austere environment, but they do the best they can. And maybe I think that was the beginning of the 2002, 2005. We had 3 hospitals in the jungle, and we were some surgical team, an orthopedic surgeon, a general surgeon, anesthesiologist, and an MEVAC team. And we were taking care of these injured people maybe for 13 years. We have been using whole blood for transfusional therapy, and different strategy that we have learned from, of course, from the from the military corps, from the United States, and others, maybe from the Britannics, from the French military people. We don't have our own protocols or guidelines. We have been taking all that you have been published, your recommendations, and I think that we are trying to do the best for our point of as physicians, and of course the military nurses that are on the field. But these kind of problems on these areas still working as a bad point for increased mortality.
And so let's move on to talk about how the military experience can help inform civilian trauma systems. Dr. Dutton, you played a major role in establishing the shock trauma civilian trauma system in Baltimore, which also happens to be where me and Kevin both trained. To what degree did the military and combat systems influence the development and evolution of the shock trauma as a referral hospital?
Yeah, it's a good story of a synergy, but I should start by saying you're flattering me. Shock trauma was established by Dr. Cowley and Liz Scanlon in the 70s and 80s. The 20-ish years I was there, the 90s and 2000s, I helped Tom Scalea sort of take it to the next level. And a big part of that was the synergy with the military. We trained anesthesia, emergency medicine, surgery residents, orthopods from all of the military training programs rotated through shock trauma in the 90s and 2000s. So that after 9/11, when the war on terror really started, many of the early physicians, early military physicians on the ground in Iraq were shock trauma graduates in one form or another, or had been through there. Very quickly after that, the military established what are called the Sea Stars training programs, which was a specific rotation of active duty military doctors and nurses through major trauma centers. And they were in LA, Miami, Cincinnati, and Baltimore. So we had a relationship with the Air Force that exists to this day, where shock trauma is an Air Force base. There's permanently stationed Air Force military medicine personnel there who both work with the trauma teams and teach. And then they rotate teams through there on a regular basis, often before deployment, to spend some time taking care of high-end civilian trauma, so multi-trauma patients, as well as doing a lot of simulations and training, ATLS and animal labs and that sort of thing. So it's been a very good back and forth. On the research side, if you look at the evolutions of hemostatic resuscitation, this is a great example of something that went back and forth. So in the late 90s, we probably saw more gunshot wounds in Baltimore than anywhere in the world. It was relatively peaceful. And that's where this concept of one-to-one resuscitation really evolved originally. And we started to apply that. Obviously, the military residents who were with us soaked it up. There were also some formal connections. I did research for many years with John Holcomb, who was the US Army surgeon when we hit the ground in Iraq. And that one-to-one concept exported from me to him, both directly and through all sorts of trainees, really got tested in the crucible of the early war on terror, and then came back to the civilian world. And that the concepts of hemostatic resuscitation and its various pieces, so balanced red cells and plasma, tranexamic acid, factor 7 in the early days, one of the drivers of it, damage control surgery, all of this was flipping back and forth. And because we were well connected with the military and we talked to all of our former trainees and we were all participating in the same research and the same efforts, there was a great deal of synergy in building this. So concepts could be tested in the military or in the civilian side, but then exported rapidly to the other and confirmed. And there are many good stories of that through the last 2 decades or so.
Well, it's a story. This is Mike Murray again. It's a story that keeps getting repeated. If you go back even earlier attempts, the person who piqued my interest in critical care was a Vietnam era physician who set up the first ICU for the Army at Letterman in San Francisco. Ron Miller developed his interest, got his start in resuscitation, transfusion practice in Vietnam. Warren Zapel at Harvard was stationed in Bangkok studying ARDS. That was a new entity back in the late 60s and 70s. And so there has been a lot of symbiosis, if you will, between the military and civilian experiences. And it goes back even into World War II, and you can cite many examples.
Hans, did you want to comment?
Well, our hospital is the only big military hospital in all the country. I think that maybe 10 years ago, we have developed five, we can say maybe it's a second level for trauma patients. Our system is completely different than you had in the United States, but the level one center for trauma patients is the military hospital in Bogota, and was interesting how we we were the trauma center for even for all the country. So many physicians were deploying to our hospital to get trainee with our surgeons and our orthopedic surgeons. I think that was really interesting, and we have maybe two or three really recognized orthopedic surgeons that even with the kind of trauma that we had in our hospital, they developed some devices to try to improve the treatment of this kind of fractures related with high velocity weapons, with the landmines. And I think that we are a referral center for military trauma and even for general trauma. But unfortunately, around the country, we have our hospitals doing everything. I know the concept that you have, that the right patient has to go to the right center. We don't have that here. We can have in the same hospital cardiac surgery, trauma, obstetrics, transplantation, and I think that is a big issue that we have in our healthcare system, because everybody knows, and the literature is really well recognized, that high specificity training hospitals could have better results when you are treating just cardiac surgery or the trauma center. So I think that is a problem. But we have learned and we have changed the guidelines and the protocols from the military trauma scenarios, from trauma civilian centers, and for our general hospitals.
And as a follow-up to this question, are there any aspects of military medicine that are not relevant or do not fit the civilian setting? Dr. Dutton?
Some. We talked about different wounding mechanisms, and those make a difference. As I mentioned, the pre-hospital care can be very different. So there's not a whole big role for pre-hospital care in the United States just because transport is so fast. Our patients arrived at shock trauma, I think 90% of them arrived within 30 minutes of injury. So if you're going to get to definitive care that quickly, there's no need for much pre-hospital training beyond scoop and run, and it would not make sense to send doctors into the field or to push a lot of technology or technique even far forward. Whereas in the military, obviously, it's very different, and the training needs to be very different. Michael, you must have some thoughts on that.
Well, that's interesting. The Israeli experience in the 1960s with the conflict there, they lost so many positions because they were transporting them out to the scene of the injury where their service member was wounded. And so you're right, we don't transport physicians out, we bring the patients back as quickly as possible. But in the military experience, if you look at the mechanism of death, many individuals in a penetrating injury or a blast injury have non-survivable injuries. Of those who have survivable injuries, the main issues are airway, tension pneumothorax, and bleeding. And 11% of soldiers who die in combat die from blood loss. And in the United States, at least, the whole Stop the Bleed campaign by the American College of Surgeons Committee on Trauma is targeted on that. And now most EMS systems have tourniquets on board. So there are some lessons that have been learned from the military and what can be done. And it's, in reality, only about 5% of individuals are going to benefit from a tourniquet at the site. But even so, for the civilian who's out there putting a tourniquet, either a one that you can purchase, or using, as Dr. Dutton mentioned, a shirt, take it off and improvise with a tourniquet. It gives people a sense of empowerment, if you will, but it also does save lives.
Yeah, tourniquets are a great example of something that was almost completely discredited and out of practice in civilian trauma that under the military crucible came back into playing an important role.
I think that the other issue that we have is related with transfusions. So I think in the last decade, maybe, we have been in troubles talking about what to do with the transfusional therapy, about this 1:1 ratio or the whole blood, and what could be the best option to treat our patients. Right now, I think that there are some protocols moving again to the whole blood transfusion therapy, but I think that this is it's completely different when you see the protocols from civilian hospitals. When you're talking about hemorrhage in an operating room or hemorrhage in patients, I think that I don't know, what do you do about using whole blood in not military trauma and not in an austere environment. Maybe I remember, I'm not pretty sure it was at Rochester or was in Arizona with the Mayo Clinic. They had some protocols for using whole blood for transfusion therapy for surgical patients. Maybe I'm wrong, Dr. Murray. I'm not pretty sure.
Mostly Texas now, actually. In San Antonio and the Houston area, some of our ambulances and helicopters are carrying whole blood. And there's research on it. It's starting in Baltimore, it's starting in San Francisco, but there's a lot of research going on. And this is another point, by the way, the synergy is that the Department of Defense, the military, funds a huge amount of research in trauma in general, much of that in the civilian community. So Baltimore, LA County, Miami, all have substantial research projects spinning that are military funded. But whole blood is very hot right now. There are big trials going underway about its pre-hospital use because it's a fine balance, right? Do you take the time to start the IV, hang the whole blood, and give it? Ideally, you do that while you're moving, but that's not always possible. So there's always this time benefit ratio you have to figure out in the civilian world. And I suspect the answer is going to be, it will be good in more austere locations, less good the closer you are to definitive care.
So team composition is very important. Dr. Garcia, besides all the other hats that you wear, you're also the anesthesia program director for the Military University Nueva Granada. Colombia has a very different training system than North America, and military medicine is highly competitive and prestigious. How do you train military physicians for trauma?
Well, George, as you said, here in Colombia is completely different than in the United States. And maybe sounds so funny because here in our country, first we have to be professionals. So I have to pay to the university to become a physician, a lawyer, or an engineer, or whatever the career do you think. And after that, you can apply to become military, Air Force, Navy, or in the Army. And after that, but there is a big process, and there are only some places for people like me. But here we have to do our career in our university, and then we become military. So after that process, we have to be as a general practitioner on the field for 2, 3, 4, 5 years. And after that, you can apply or you can ask to become specialist in surgery, orthopedics, dermatology, anesthesia, whatever you want. So your commander, your in the Air Force, in the Navy, or the Army, they study the possibilities for your application. And I remember that maybe 10 years ago, the Army said we only need trauma teams. So if you want to become a specialist, you have to be an anesthesiologist, orthopedic surgeon, or general surgeon. And that was maybe for 4 to 5 years, but right now we are still having some veterans, we are still having the relatives of the military people, so we need different kind of specialties. And talking about trauma training for military physicians, I think that we have two different scenarios. For general practitioners who are working in the battalions, in maybe working even with some mobile brigades, we don't have the enough training for this kind of physicians. I think that you need to pay. Sometimes I have to do it to do the ATLS program. But I think that maybe right now there are some trainees that are developing the program for the military trauma care in our army. But if not, you have to pay for this civilian course that are in charge of the Colombian Trauma Society that is maybe sponsored by the American College of Surgeons. And in our hospital, sometimes we have the military people to go back, but it's not the same way that you have in your hospitals when you have some military physicians and they are deployed to Iraq of Afghanistan, and they go back to your civilian hospitals and they are working in the OR or in the emergency room or in the critical care units, and then can be deployed again 1-2 years later. Here we are just working in our military hospital, in our second level military hospitals, but we don't have this possibility to work in civilian hospitals. So it's only maybe it's only the military hospital in Bogota who can train these kind of physicians.
I'm glad you brought up the team aspect. One of the secret sauces in Baltimore is that the helicopters, the statewide medevac system, is run by the state police rather than by a private contractor. So it's a public service. And both the pilots and the medics who fly on those helicopters are mostly ex-military, and they are wholly trained at the Shock Trauma Center. So all their training in rapid sequence intubation, resuscitation, field care, ATLS, all of that happens at Shock Trauma. So it makes for a very integrated team that extends all the way into the field.
And Dr. Garcia, what other non-physician providers have a role in military trauma care? How are they trained?
Well, we have also some nurses, physical therapists, psychologists. They're really important because of this post-traumatic psychological disturbance that we have seen in our people. Maybe you have had the same with your veterans. I think that is really the same related with the training in trauma for the physicians. We have to do our own programs in the Army, separate with the Air Force, separate with the Navy, to train these people. I think that we are lacking. We don't have these big programs as you have.
Well, excellent. Thank you, everybody. That's been a great discussion. Do any of you have any final comments for us before we end?
Sure. This is Rick. I will just say military and civilian trauma care should be synergistic. Synergistic science, synergistic training, and as much back and forth communication as we can achieve. That will advance both the most rapidly.
And Mike Murray here, and thank you for doing this. But my experience is it's kind of a two-way street. We're talking about the lessons we can learn from the military, but pulse oximetry and intraarterial blood pressure monitoring was developed by Earl Wood in 1943 when he was studying why pilots were passing out. He built a centrifuge, and one of the results of that, as there was with the space program, there are a lot of technologies developed for the military that found a role in the way we manage patients nowadays.
Yes, I agree with that, and I think that we can deny that. We have to accept that the war and the military trauma have been involved in the development of different strategies and treatments for civilian trauma patients. So I think that we need to move in the both sides, and we need to check what is the evidence in both the scenarios to finally get the best option to our patients. And thanks for inviting me here with you.
Well, we appreciate it. Thank you all. You guys are all very busy men, so we very much appreciate you taking time to talk to us today about this very interesting topic. We also want to thank Doc Matters for hosting the panel. You can find this podcast and our prior podcasts on the Trauma Anesthesia Society's Doc Matters page. Thank you very much.